Uh, we are really, thankful to you that you have agreed to be the first one of the year, and we're lucky to have you here, sir.
Thank you.
And I am from Jammu and Kashmir, and we are in the, we are implementing Ayushman Bharat Jan Arogya Yojana Sehat, which is we cover all the, entire population. So that way we are lucky. Your support is always there with us. And today you will be talking about the convergence administration and service provider engagement in Ayushman Bharat Jan Arogya Yojana. We are eager to hear you. And I think without saying much, I thank you once again. Thank you, Dr. Rajiv, for an excellent arrangement of the webinar. And I hand over again to you. Thank you very much.
Thank you so much. So today, the beginning shall be made by Dr. Pankaj Kumar Arora, who is presently working with the National Health Authority as director. He is heading the divisions of convergence, administration, hospital empanelment, hospital operations, and beneficiary engagement. He is involved in policy making and implementation of the world's largest health protection scheme, that is Ayushman Bharat Prime Minister's Jan Arogya Yojana. He's also working on getting all major schemes of Government of India, like CGHS, like Central Armed Police Forces, etc., on single IT platform. Dr. Pankaj Arora, he has done MBBS from Allahabad University, and he has also done MS surgery from Meerut University. He has been a gold medal recipient in the surgery subject. He has served the public health sector for the last, now working for the Government of India, more than 20 years. He is a fellow and counselor of American College of Surgeons, India chapter. He is a life member of Association of Surgeons of India, Indian Hernia Society, Society of Endoscopic and Laparoscopic Surgeons of India, and Minimal Access Surgeons of India. He is also a member of International Commission on Occupational Health and also a member of Indian Association of Occupational Health. He is also a fellow of American College of Surgeons, fellow of Minimal Access Surgeons of India, fellow of Advanced Laparoscopic Surgery, Hepatopancreatobiliary. He is also a fellow of Indian Association of Gastrointestinal Endosurgeons. He is also a fellow of International College of Laparoscopic Surgeons. He is a joint secretary of Delhi State Chapter of Association of Surgeons of India. He is executive member of Delhi Medical Association, and also he is executive member of Bureau of Indian Standards. And also he has interest in St. John's Ambulance, Red Cross, and various other activities. It is interesting to note that Dr. Arora has also served as an administrator of Indian Railways Wrestling Academy, as well as administrative captain of badminton and volleyball of the Sports Association. He has deep interest in driving innovations as well as ensuring that onboarding as a team is done in whatever capacity he has worked. Now, today's subject is of deep interest to all of us in the Academy of Hospital Administration, as the subject is so interesting that it is going to be reforming or restructuring the entire hospital sector in the country. The Pradhan Mantri Jan Arogya Yojana as it is involved with the health and wellness centers and hospital empanelment and cashless health protection scheme of rupees 5 lakh to a substantial population of the country will ensure development of hospital sector as well as its affordability and accessibility on a long-term basis of our country. So, in this context, the area of focus today's interview discussion that Dr. Arora is going to talk about is about hospital empanelment under PMJAY. Now, I would request Dr. Pankaj Arora to tell us about the subject. Welcome, Dr. Pankaj Arora.
Thank you, sir. Thank you, Rajiv, sir. And thank you, Dr. Yashpal and Dr. Sharma, the President and the Executive Director. I've been mentored by none other than Dr. Rajiv Kumar Jain earlier in my career. And he is one of the very, very solid person who can train you well and take you to heights. So I'm really happy that he is in as a part of AHA and he is got a position where he can affect people. Uh, just to start with, before we start the presentation, I just like to tell you, yes, this health in India has been taken very seriously by the government right now since 2017, when there was a national health policy which was made, and out of it came two children of it. One is the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which is a scheme which gives the population 40% of Indian population, which is marginalized, coverage for secondary and tertiary care. As well as there came the Ayushman Bharat Health and Wellness Center, which were to be made to the number of 1,50,000, which has been achieved near in last week, and the Prime Minister announced it on his Twitter account, and that has also been now completed. So these two things, the first thing takes care of the secondary and tertiary care, and the second thing, that wellness center take care of the primary care and delivery of medicines and basic care to the population of India. So now I'll just present my screen to you so that you can be able to see my presentation. Just a second. I'm not able to share, Rajiv sir. I don't know why it is not. The share option is not clickable. I think I have to get the rights to share it. I think so. Let me try again.
And ensure that he gets the rights.
Yeah, I didn't have the rights right now. So just before till the technical team does the job, I'll just tell you about what basically the scheme was all about, and what was thought when it was national health policy was being made, was to achieve the basic purpose of SDG 3.8, which is universal health coverage to the people of the country as well as the world. So India was just to put a step forward into that,
Yes.
achieving that goal of 3.8.
We want to share.
So let me try again.
Huh?
This I'm not able to share, sir. Can I? I don't know why it's not being. Usually, it is very easy. The cancel one is giving the option, but the share one is not. But then now let me see entire screen. No cancel. No. A window. Yeah, I can share now. I think. Are you able to see my screen?
Yes, now it is visible.
So let me go into the presentation mode then. So before we talk about the hospital empanelment as such, so I was talking about the universal health coverage. There is a cube which is there, which basically tells you about this is a very known WHO health cube. So it tells you about the distance you have left between the amount of money you need to spend, the amount of service you need to give, and the amount of people you need to cover. And the basic purpose is to give a quality healthcare to everyone at every place without any financial hardship. So that's what is universal health coverage, and ABPMJ is just a step forward towards it. So it basically, I'll just give a brief about ABPMJ to you first. As Dr. Rajiv has already told you, it gives every family a health cover of rupees 5 lakh an year, which is recouped every year. If you spend 4,90,000, it will be recouped every year. But if you spend more than 5 lakh, then you have to pay out of your pocket, unless it's a cancer or rare disease, which in which definitely RAN HMDG comes in. That is Rashtriya Arogya Nidhi as well as Health Minister Fund. So those two things can be added over it if you have a cancer or rare disease. There is no cap on family size or any kind of age or gender. So the person who is the family in charge, his full family will be taken up. If he has 6 children, also it is a part of that. It is being implemented in several modes. One can be insurance, in which insurance company takes a tender and gives the payment to the hospital finally and checks the bills. Second is a trust mode, in which the state is a kind of a payer and he checks the bills and finally pays to you. And third is the mixed mode, in which the insurance part is only one part of the 5 lakh, that may be 1 lakh, 1.5 lakh, 2 lakh, according to the premium is there. If the bill shoots above it, then the state pays the bills. I'm sorry. Benefits definitely can be availed anywhere in India because it's a portable scheme. That's one of the good features of it. Portability means that a patient of Jammu and Kashmir can take treatment in Delhi, or or a patient of uh, Bihar can take treatment in Kashmir, so and so forth. And only the three states which are not covered are Delhi, West Bengal, and Orissa. So those patients can't take treatment anywhere. But any other patient can get treatment in those states because we have empaneled hospital there also in few hundreds. So the purpose of this, the main feature of this scheme is it's totally paperless also. That it doesn't involve any kind of paperwork except the paperwork you do in the hospital, and it's a cashless service given to the patient, and patient has not to be charged anything, as it will lead to the it will lead to the flaw of what do you say, making the main purpose of scheme go away. That is, the patient should not have any financial hardship and there should be no out-of-pocket expenditure. So everything is cashless, and person goes to the hospital, gets the checks that the person in the hospital checks that he's a beneficiary or not, and admits him, treats him, and uploads the bill, and the bill is paid by the government, especially by the state from which he belongs. And the one of the main also things is that everything from the first day when he becomes a member is covered, all the diseases. There's no no pre-existing condition which is not covered in this. And as I told earlier, it is basically a secondary and tertiary care. OPDs are not involved in this, except the COVID test, which we have included in this package. So this is the scheme which gives a really good protection to 40% population of India. That means 10.75 crore families of India. That means 54 crore people of India. The base is going to increase. Rather, it is increased to 12 crore families now, and it will be rolled out soon. So it was already the largest health assurance scheme. Now it becomes more far away from any other country. So empanelment is done who are empaneled actually are the three kind of hospitals. Most of the people may be from the private sector in this association. So one of them is private hospital, and it is they are empaneled as per the criteria which we have defined in all the states. It's a two-tier empanelment process except Delhi, West Bengal, and Orissa, where we call them a non-PMJ state because they have not taken up the scheme. So these states are directly empaneled by us, and I'm the director for empanelment, so I take care of that. But the public hospitals are deemed empaneled if they apply. So if they apply and they just put up the documents, they will be empaneled. Same goes with the GO. The public hospital usually empaneled by the states, and GOI are by directly by the NHA. Sorry. Right now we have reached a figure of 26,000 plus hospitals. It was higher, but we have removed few hospitals which were not performing, and we have de-empaneled them. And we're going to de-empanel any of the hospitals which will not be performing and giving services to our patients. The target is not to increase the empaneled hospital, but to increase the empaneled hospital which give proper treatment to the beneficiaries. Uh, we have nearly 14,000 plus private hospitals at present. Karnataka and Uttar Pradesh lead them, nearly 30, nearly reaching 3,500. Gujarat, Andhra Pradesh are nearly 2,500, and very small figures you can see down. Even Delhi has few hundreds, and Daman and Diu and Andaman don't have the private hospital usually, so they have public hospital panel, but there are few of them, and they can get the treatment in the nearby states. For example, Andaman people fly to West Bengal, get treatment there. And so the point of interest of this talk, how to get empaneled. It's very simple. It's paperless, and you need not to reach anybody. You should be interested in getting empaneled. And there is a website of ours. I'll be sharing the link to all of you. It's pmj.gov.in. So we will be sharing the link to Rajiv sir, and it can be shared by him to any other, all the people in the association. And you have to just go and fill the application. For that, you have to create an account and on website, and the account will be activated as per by the OTP on your phone, and then you can submit your application with filling the required fields as well as uploading the required documents. I'll be coming to detail of what will be the mandatory requirements for the empanelment and what you need to upload. So those application, when finalized, go to the district empanelment committee, and he verifies, or the committee verifies the documents, goes to the hospital, does the physical verification. But in case of a NABH or ABPMJ bronze certificate, usually it can be fast tracked because that inspection has been done by one of the agencies which has been reviewed. Once the verification is done, if some documents are lacking, they wrote right back to the hospital and take the detail required. And otherwise, if it is totally complete, then application is accepted and report is submitted to the State Empanelment Committee, the SEC. And if there is a flaw and you don't meet the requirement, it is rejected as such. So the SEC finalizes and sees the report of the DEC and takes the decision how the hospital empanel is correct, and if it is correct, they empanel the hospital. Otherwise, they don't empanel or ask for details or can reject it. And hospital is informed about the result and reasons online only, and they will get a email and the response on their account. I'll be explaining the SEC and DEC's committee in detail afterward. This I was trying to address first the process. The similar process will be done for the non-PMJ. I'll come to that also. But what are the documents which are needed for empanelment? So you should have a hospital registration by the state government, the fire and pollution clearance, the AERB certificate, PCPNDT certificate, biomedical waste certification. If you are having an NABH or NQAS certification, you can fill it. Or you're having a ABPMJ bronze certificate, you can fill it. You should have a pharmacy. Blood bank should be there, or either there should be a tie up to the nearby blood bank, and it should be ensured that the blood will be available. The ambulance service should be there, or a tie up should be there for the ambulance service, and the faculty has to submit all the registration certificates of his or her, if it's a specialist or if it's a general practitioner, or if you're applying for a specialty, those specialty doctors certification needs to be uploaded. And also the need is of the bank details. You have to fill the bank detail, and you have to submit a cancel check with it so that the details can be verified, as well as you have to fill the PAN number, and a PAN card detail has to be, PAN card copy has to be there so that it can be verified. Coming on to civil infrastructure measure mandatory is a bed area of 80 square feet should be there or more. There should be a backup electricity. Total bed stand in normal district should be at least 10 beds, except 5 beds which are allowed for the aspirational districts. We should, if you're applying for a surgery recognition, you should have a fully equipped OT, and gynae should have a fully equipped OT as well as labor room. For sterilization, there should be a facility of central sterile supply department, which will be checked. Otherwise, if you're not having the certification, it will be checked. And as earlier told, blood bank should be there, and radiology features should be available there in the hospital or nearby. The toilets,
Pankaj, your presentation is not visible at the
it has gone,
moment.
sir?
Yes, it is
Just a
not there.
second. Just gone or earlier? It has gone earlier.
Earlier was also not there.
Sir, I have shared the screen, so just a lot. So I was totally not showing a presentation from the very beginning,
No,
sir.
it was showing for a
Let,
while, then it disappeared.
let me do it again, sir. No problem.
Yeah.
Just a second. Is it visible now, sir?
Not yet. Yeah. Yes, now it is. Make
Okay,
it full screen, please.
I'll do it, sir. What was the last slide you saw, sir?
No, from the first slide, the slides were not there.
Okay, just let me go fast to this. Did you see the slide? This one was there.
Yes, civil infrastructure mandatory requirements is visible now.
So, so this was seen the hospital details which you are having. I was telling you is
No.
the. So let me go fast on this.
Yeah.
So there are three kind of hospitals: public, private, and government. And then I told except three states like Delhi, West Bengal, and Odisha, the other states are PMJ hospitals, and we call these three states non-PMJ because they are not taken up the scheme. The 26,000 total hospital, out of which 14,000 plus are private hospital, which I'm panel. This was the major thing which I was showing. I think nobody told me that it was not visible. That's why I did continue. I was thinking that was seen.
I thought you were conversing before the
No, no, sir.
actual.
So no problem. So this was again, I'll just go through. There's a healthcare provider which submits the application. For submission, they need to go to the website, which is
Could you
pmhospital.pmj.gov.in.
start with the first slide? I think that then you can run over. I feel
So
that will be useful.
from this,
At the moment, is slide 7 visible?
is it changing or not, sir? No,
No, it is not changing.
strangely, sir. I don't know. Let me share it again. Should I
Uh,
start from the beginning? You're saying?
yes, that will be useful so that
Yeah, sure, sure.
viewers can see the
No,
structure
no,
of the presentation.
no problem. Let me again do it. I don't know Google. Usually we don't use Google Meet, so we have no idea what much.
Yes, it can happen.
We use Teams or otherwise Zoom.
I know. I
So
know.
now it visible, sir?
No, yes, now,
So,
but
so
not.
let me don't go not go to slide mode because I think it's going now. It's
Now it
changing.
is moving, and now you go to presentation mode.
Is it now visible? The first slide.
Yes, yes, it is visible.
So now it is in a slide mode.
No, not yet. You have to go through the slide mode.
No, I've done it, but it's on my screen. It is slide mode. I think it will reach you soon.
All right, you can continue with this, and this is the second slide visible.
Yeah, correct.
Yes,
So this is a slide which tells you about the scheme.
right.
5 lakh family cover, no cap size on the family, no capping on the family size. Three kind of implementation: trust, insurance, and mixed mode, which I explained to you. Benefits can be availed anywhere in India. It's a portable scheme. J&K person can take treatment Bihar person can take treatment J&K, in Chennai, in any other state, except that what the basic thing is that the Delhi, West Bengal, and Odisha people can't take treatment anywhere because they are not the part of the scheme at present. But all the other states can take treatment: Delhi, West Bengal, and Odisha, because the hospital are panel with us. It's a completely paperless and cashless scheme. Pre-existing conditions are covered from the day one, and it basically treats. We give the cover for sanguinary and tertiary care, not for OPD, except COVID testing. So there are three kind of hospitals. Sir, the third slide is visible now.
Uh, Not yet.
I've changed the slide. That's why I think there's a
No,
delay.
but it is not only showing the second. Now it is third slide is visible.
All right, so let me do it this way because it is not turning in the slide mode. So there are three kind of hospitals: public, government of India, and private. The public hospital and private hospital are paneled by the state. The government of India hospital are paneled by us, and we also panel the private and public hospitals in Delhi, Odisha, and West Bengal because they are not running the scheme. So I do it directly. So these are the three kind of hospitals. So on the others, now the fourth slide is visible, sir.
Yes.
So I think I'll go by this way only. So there are 26,000 hospitals at present which are paneled. Out of them, 14,000 plus are private hospitals. And this is the slide which shows you how to empanel yourself. They have to submit the application. Are you able to see the slide?
Yes, of course.
So there's to be an application which is submitted in the hospital empanelment module portal, and the ID is hospital pmj.gov.in. So you have to create an account first there, and then you have to submit your application. Once the application is submitted, the district empanelment committee will go through the documents, do the physical verification by going to the hospital, and if you are NABH and ABPMD drones, they will have a fast track. And if they have something missing, they will ask for the details. If all are right, all things are right, they will accept your application and submit a report to State Empanelment Committee for approval. Otherwise, they will reject it. So the State Empanelment Committee finalizes and decides on that application a report that the hospital should be empaneled or not, and the results are conveyed to the hospital. And now coming to the documents which are required, that's what I was showing. The hospital registration from the state, fire pollution clearance, AERB, PNP, PCPNDT certification, BMW certification, NABH, if they're pharmacy. The blood bank has to be there, otherwise there has to be a tie-up. Ambulance has to be there, otherwise there has to be a tie-up. And the doctors have to put the registration certificates and upload them, which are registered by the state in which they are practicing. And the bank details should be there, which is filled. And for checking that, a cancelled check should be uploaded, and the PAN card details should be filled, and a PAN card copy should be uploaded. The area of the bed should be at least 80 square meter for per bed, and you should have minimum 10 beds in the hospital if it is not an aspiration district. If it's an aspiration district, you should have 5 beds or more. If you are applying for the surgery, you should have fully equipped OT. If you're applying for gynae, you should have a labor room too. If you're applying for critical, you should have a ICU. And the hospital facility should definitely have a center trial supply department, which gives trial instruments for any procedure. They should have a blood bank, as told earlier, and a radiology inside or tie-up. Casualty should have adequate bed facility and toilets. So just the other things which are generally required, should we have a water cooler with clean water supply. There should be a power backup, electricity backup should be there. There should be computer and internet connectivity, because you need to upload the bills and do the basic BIS, that is beneficiary identification and transaction for funds, and scanning facility should be there. Beds with mattress should be there in the ward, with stands, wheelchair should be available, oxygen supply should be there, or oxygen cylinder should be there. OT should have good OT table with lights which are working properly, suction apparatuses, pulse ox, cardiac monitor, and all the gas supplies for anesthesia. The CSSD should have autoclave and sterilizers. ICU should have ventilator, defibrillator, oxygen cylinders, ICU beds or oxygen supply directly. And there should be a medical record section, which should be paperless or paper-based. It can be both, or HMS can be there. Now coming on to the non-PMJ state, I think again the slide would not be visible. I'll just change it. Now this is the non-PMJ state. If you are a hospital in Delhi, West Bengal, or Odisha, you need to do this again. The similar thing follows, but now NHA does the verification, and we don't do the empanelment until you are a NABH certified or a CGHS empaneled hospital or a ECH empaneled hospital, or you should have a ABPMJ bronze certification or QCR certification. So you should have minimum them, then you should apply, and I'll check it and I'll do the approval if it is fine. Otherwise, I'll refuse it, or I will ask for clarification. Yes, the procedure otherwise same, but you should have a certification, because there is no physical verification from NHA. So just making you know that what should be the real, usually the time which is there required. I think it's wrongly written to 15 days down, but it is 30 days in the SHA. So application is submitted, the physical verification done. This should be done by within 15 days by the DEC. You should scrutinize the document, do the physical way, and submit a report within 15 days. And approval by SHA or SEC will be done in next 30 days. It can take more if SHA sees that they need to drill on it. So these are the two committees which we were discussing, DEC and SEC. Let us see what they are. First of all, let's go to State Empanelment Committee. So this is led by the CEO of the state. It should have a director level officer within the committee, which is the medical officer. There should be 2 state government official from the department. And if there is an insurance mode applicable, there should be a member of the insurance company which should be a part of it. And if SEC wants, it can take any other member, or it can ask insurance company to do the mandatory checking and in scrutiny. and it is basically responsible for the checking the recommendation of DEC and doing the empanelment and making sure that that MLL provider meets the minimum criteria. And also it takes care of the de-empanelment, as well as it takes care of the transparency which is there, and any queries which are there from the hospital will be answered by them. All the applications should be time bound, and there should be appeal which should be time bound. So DEC is basically led by the CMO of that area, and the district program manager also is a part of it. And if there is insurance, the insurance company is a part of it. They basically do the scrutinization of the document as well as the field verification. Now coming on to one of the good things for the hospitals which we have made in recent times, that there should be some incentive of good quality. So the good quality, for example, NABH has certified you as a full accredited hospital, you get 15% over the base package. If a package is of 10,000, you will pay 11,500. If you're entry level, you'll pay 10% more of the package. If you're in a metro, then you'll get again 10% more, or you are an aspirational district, you get 10% for that. And if you're running a PG course or a DNB course in a specialty which is in panel, for that specialty, you'll get 10% higher rates. And if we have given you quality certification bronze one, so you'll get 5%. So it is a compounding incentive rather than a simple entrance incentive. So if you'll have all the things, like if you have a NABH accreditation as well as you're situated in the metro and you are running a PG course, so you will have not 35% but 39% of the incentive, which is huge incentive actually. And recently, the package rates have increased. Uh, the president was telling about Jammu and Kashmir. Jammu and Kashmir is one of the state which has gone and achieved, it's going nearly achieving UHC, and is giving its treatment to all the citizens of the state through the Ayushman Bharat Pradhan Mantri Jan Yojana and their scheme, which is known as Sehat. Similar as with Uttarakhand, which has reached that kind of, and several states are following that, going to there are 5 of them. And there are several packages which we have made, and state is not bound to go to these packages, but 5 states have already gone to 2022. We started with 1,393 procedures from the health benefit package 1.0, which has definitely allowed state to change the package and do the local walking and get the appropriate rate for the package which we have uh, taken in the HVB 1.0. Then in 19, we went to 2.0, which we increased the procedures up to 1593, and we allowed 2 specialties to be booked, like general surgery and knee surgery can be booked together now. Earlier it was not. Then in 2020, we launched 2.1, in which we increased the procedure to 1669, and we included the organ transplant like renal transplant, corneal transplant, and tissue transplant like corneal transplant. And further, we went to 2.2, in which only we increased the prices and just added one more package, uh, but which was definitely black fungus because it was coming up after the COVID, so we included it, and we increased the price of 400 plus procedure. The 2022 had really gone a step further and given you very good rates. We have added 365 more procedures. Now the total is 1949, and the differential pricing for the city we should always believe should be there. So tier 1, tier 2, and tier 3 cities have a different prices. The highest being in the metros, and palliative care specialty was also introduced. So basically, how we reached here in 2022, we did it in the bundled way. Like, all the payment is done as per package. For a surgical package, it's all inclusive, and for a medical thing, it is made on per day basis. And for unspecified pocket which are not there in the list, they should be written to the state, and if state she thinks they are eligible, they will pay for it. So the flexibility is there for the states to change it also, and this was designed with the expert committee of every specialty in coordination with the Department of Health Research. So now we have 27 specialties and 1949 procedures and differential pricing. Palliative care is included. As I told, the procedure are added, and there is rationalizing of price as per evidence on cost, stakeholder consultation, as well as from the expert committee. Thank you. I don't know if this slide was visible or not. This is something which is stopping.
Yeah, this was not visible earlier.
This was, sir.
No, this was not also visible.
So just because on the slide mode I continued, I think, for some time.
Yes,
Incentive was visible, I think, if I'm right.
yes, it was visible.
So this
This
is
slide was
this is
visible.
a step ladder
Yes,
thing which I was discussing about the packages.
right.
We have increased the things over the period of time, and good rates are now available if the state wants to take it. The problem is that states thinks if the rates are available in the lower cost, why should they increase it? So if the hospital is willing to do it in that way, they will be doing very well do it. And I think the feasibility is there of small hospital at good rates, and the big hospital can't do it. I can understand that too. But now the rates are good, and the big hospital also chipping in. And this was the thing which I was telling about, that there are 27 specialties and 1949 procedures. So that was the brief thing about empanelment, and any kinds of queries anybody wants. And if this application is stuck somewhere and you have filled the things, please tell us. We are following it vigorously, and we'll make like to have all the people who are interested in working with us on board, and help the achieve the universal health coverage SDG 3.8 goal, and give us our people good healthcare. And I think ABPMJ is one of the scheme which will take care of the running cost of any hospital, and a good amount of hospital which are coming up are also getting funding from the scheme which we have introduced, in which the fund can be availed, and the viability care funding can be done if required, and you don't have the fund totally to take start a new hospital. Thank you, sir.
Thank you so much, Dr. Pankaj. Very lucid, very comprehensive, and a presentation which opens insights as to how the government of India, along with the state governments and other insurance companies, are moving together with the health sector, especially the hospital sector. One remarkable insight that we got was integration of quality and pricing, and the quality gap, viability gap funding mechanism that is available now to develop the hospital, where hospitals find it difficult to have their running cost. Another thing which was notable was expansion in the packages as well as in the pricing, and how it has been evolving along with the experts and along with the practitioners in the subject. And also, you have very clearly mentioned how the quality landscape in the country, NQAS or NABH or CGHS empanelment or ECHS empanelment or other empanelment processes which are existing already in the country have been integrated in by NHA in terms of operationalizing and smoothening the process of empanelment. No doubt, this is a continuous process, and I am sure that this process shall evolve further as we go along. So now I open the floor for discussions. Any of the attendees are welcome to unmute and ask the question. I see one hand raised, Dr. Junaid and Dr. Insha. Yes, Dr. Junaid, you could go ahead.
Good afternoon, sir. It was very enlightening to hear from Dr. Pankaj sir and rest of the members on the board. Sir, my question is, I'm actually from Jammu and Kashmir. I'm working in SKIMS. It's a tertiary care institute. I'm working as a senior resident here in hospital administration. Currently, our TMS, the transaction management system, which is working, we have 2.2 SBP 2.2 in use. 2020 is not functional as of yet. Yes, sir. And also, I have some questions regarding this. There are some bottlenecks here, and then the turnaround time for pre-authorizing a query is around 5 days only. Here in a tertiary care institute, the patients usually get evaluated for a long time, like patients who have to be diagnosed for a specific cause. The turnaround time should be more than 5 days. And if we don't authorize the patients, like pre-authorized patients, within these 5 days, our cases get rejected from the insurance company. And there are few instances where the queries are raised from the insurance company, which are like which are not justified. Like some queries, for example, if we have done a high investigation in a patient like CT scan, they ask for X-rays and all. And in some instances, they're saying anesthesia notes for like locally done procedures. That's sort of these bottlenecks we encompass while giving the patient benefits.
Just coming to that, there is a criteria for there is a criteria for pre-authorization. It should be done in 6 hours usually. The pre-auth is approved. If you raise a pre-auth, it will be approved in 6 hours. If they don't do it, I don't think there is an insurance company right now. Is it so in Jammu and Kashmir now? It's a trust mode. Earlier it was an insurance company, but now I think it's a trust mode. But whatever the reasons that they have to give the pre-authorization within 6 hours. If they do not pre-authorize, there's a this what we say auto pre-authorization is there, and you get that thing. But for the bill submission, if you don't submit in the time, which is 7 days, you will not be able to submit the bill after that. There's a manual for submission and what we say the uh, process of submission of bill. If you would like, we can arrange a lecture in for JNK, and the lectures are regularly taken by my team, and they take care of all the hospital, all the states in a and there's a schedule for that. So I'll just share. You should share me a number in the chat box, and my team will coordinate, and they will do it for full Jammu and Kashmir, not for you only, but full JNK. If the problem is there in one hospital, it can be another hospital too. So the training can be done, and you can reach to the this SHA CEO, and you can ask for a training for getting this issue resolved. Because the only thing to this is training. Because if you need to have if you are a senior resident, you understand local anesthesia is also anesthesia, and as per the rules of Government of India, there has to be anesthesia now. This is a compulsory thing, and you can't write and even I'm a surgeon too, and we even in local anesthesia we put the name of the anesthetist when we do the procedure, and it can be not done away with. If it is required, you can put a note. It's not a problem. And the rules are being made by the committee, which is headed by the senior most people in the country, and they have made the standard documentation which our doctors check. So they have to tick every box which is written in the document. So that the basic requirement, if it is there and you can do it, then please do it, and then the rejection is not there. That's why we ask you. There is a standard treatment guideline for every procedure you do, which is available on the website. Please go to the standard treatment documentation guidelines with the before filling the this claim which is there. So when you read for that specific procedure, the standard treatment guidelines, you will know what documents are needed, and that documents, if are there, there is no rejection of the bills. Thank you.
Yes, Dr. Insha Rahman also wanted to ask a question. Dr. Insha. Then Dr. Dinesh Sehgal. Dr. Insha, you could unmute and ask if you want.
Dr. Pankaj, thank you so much for the information.
Dr. Dinesh Sehgal, yes.
Yeah, Dr. Pankaj, Dr. Rajiv ji, thank you so much for the information. Sir, if you can please elaborate for small hospitals, what would be the requirement for CSSD, radiology?
So we can what I can do rather than elaborating it here, I can share the document to you. You can go through the document. There is an empanelment guideline which will be sharing if required, and you need to have minimum 10 beds. That's for sure. If you have 10 beds, then you need to have a certification of blood bank. In the CSSD, you should have a sterilizer, which should be able to give you the instruments which are needed for any kind of procedure if required. And the radiology, if it is there nearby also, it will do. That's not a problem. Blood bank and this ambulance type should be there in kind of any requirement.
Thank
But
you.
I'll give you the full document so that you can.
So much.
It is available on the website. I don't know. People have not visited it. The pmj.gov.in has all the documents which are needed by you. It's available. But I'll share the copy to Rajiv sir so that he can share it to you.
Thank you. Thank you so much.
All right.
Right. And Dr. Junaid has shared his mobile number.
Sir, the Jammu Kashmir training, I'll share what date it is, because all the states are getting training. There's a third round going on right now. And last 2 months, we have done already two rounds for every state. So the people are allowed to join, and they have a training with the state health authority if they want also. They can do it from there also, but we'll do one training for them again.
Yeah. So in today's audience, we have Dr. Rajesh Palla, also from Board of Executive of Academy of Hospital Administration, a very senior member of our hospital administrator community. Dr. Rajesh, would you like to make any comments or ask any question? Yes. You need to unmute, you're not audible.
I think so. His screen freeze every sir.
His screen was frozen at the moment.
I think.
Meanwhile, Dr. Insha has now raised her hand. Dr. Insha Ahmed.
A very good afternoon, sir.
Good afternoon.
Myself, Inshar Rahman, and I'm basically from Jammu and Kashmir. I'm working as a nursing tutor. So, first of all, I'm very thankful to AHA administration for planning so many programs in nursing colleges, either in private sector or government sector. So one more thing I would like to suggest. So many programs have been conducted till now in all over J&K. So one more thing, I think there must be difference in, because I have attended so many programs, like 3-4 programs I have attended, and I want there must be change in the topic, so that all the audiences or the teachers or the spokesperson, they must be learned to new things, new skills should be improved in the students also, nursing students also, and also in the faculty of nursing colleges. There must be also improvement in good skills, knowledge, because all the nursing students, it's not necessary they will work only in the college line only or the teaching line. They are, most of the students are going for the clinical experience. So there must be a change in the topics, so that their skills, their knowledge must be improved, in order so can all the students can give the quality of care what the patients need in day-to-day life. So I would like to suggest this thing, and I hope this will be very fruitful to all the nursing students, all the health professional students, and all the faculty members. Thank you so much, sir.
Sir, there is no question here, but I'd like to tell something to all of you. Sir, first of all, everybody, I don't know, everybody is registered under the HPR or not, Health Professional Registry. Uh, I think everybody can do that, and there is a hospital registry as well as the health professional registry. In some time to come, we will not be allowing any hospital to get empaneled on rather 31st January. We will not be allowing any hospital to get empaneled at ABPMJ unless it's a HFR registered hospital. Well, the health facility registry has been done by it or not. It is to be taken care of. Otherwise, it will not be able to register. Or otherwise, if even the hospital which is registered will not be able to get the claims if it is not registered in the health facility registry. That's through the Ayushman Bharat Digital Mission. We are going to register 3 things: the hospitals, the doctors, as well as uh, uh, the in charge of the hospital. So these are the registry which are there. I'll request all the hospitals which are there to register on that HFR, as well all the doctors to register on the HPR. There is a nursing registry also which is happening. Miss Insha should kindly ask all your nursing people to register on that, because it will be verified and there is the opportunity for them to get the job, and there is a job portal which will be coming soon for nursing people to apply abroad through the same channel. So please do spread the news and allow them to register on the health professional registry. All the nursing staff, all the doctors can register on that, dentists, all can register on that, and they should be a part of it, because all the information will be flowing through that system in the time to come. So,
Yeah.
Okay, thank you so much, sir.
all right.
Now, Dr. Santosh wants to ask a question.
Yeah, good afternoon. So I have 2 questions. One is regarding this government announcement to incentivize the hospital for digital kind of the implementation, software kind of thing. So how does it work, and how should a hospital kind of contact with the NHA? And second question is regarding this medicine. In case of medicine, government has put a package of 4,800 for ICU cases. So I was just wondering how it could be for a primary level hospital, secondary level hospital, 4,800 rupees is can be managed, but for a tertiary care hospitals, I don't know how the pricing will work.
You're not audible, Dr. Pankaj. You're not audible.
Okay, sorry, I was muted actually. The first question first. So The first part you asked how to get the incentive thing. Once you register on the HFR and you fill the details, the incentive will flow to you at the DBT only, and there's a detail of the account which you'll be filling in. So as per the rules, the DBT will be done to your account. And if I'm not sure exactly what incentive is there because my other team is managing it, but yes, there is incentive for sure. I remember that in the meeting it was discussed, and it will definitely come to you if when you fill the details because the account number is also part of it. And second question, that the rates of ICU, they have changed, and a few states have agreed to the HV 2022, and they are higher in that. And you can check the packages on the website, which are available. And yes, some rates are good, some rates are bad. You don't talk about good rates, only talk about bad rates. That's the problem, actually. So
No, it's not. We definitely talk about good rates. There are a lot of super specialty tariffs is quite good. I mean, say that it meets the requirement of the hospital.
So we are going to reduce those and increase this. Actually, we are going to balance it. We have already got which
So
are
if you are talking in a lighter vein, it is okay. But majority of the cases are medicine cases, and I don't know any tertiary hospital. And
the medicine cases rates are per day, and I think it's 2,300 if I'm right.
no, 4,800 rupees is the rate, which includes everything: diagnostics, the medicine care, everything, ICU care, and room rent, everything.
Correct,
So,
correct.
do you understand? I mean, globally, talking about average rate is around 25,000 to it goes up to 1 lakh rupees. So, in the scenario, we are not saying that give for all the cases. There could be cases which can be handled.
So there is a thing which has been recently added, that the higher end medicines which are there can be you can just go through the package thing on that, and then we can discuss it, because the slight change in the if the patient is sick and the patient is going to need an critical thing and it's a medicine patient. So we are doing a project on DRG in few states. Jharkhand is one of them. So once the results of that come out, and we'll be implementing the DRG2, that is diagnostic related groups, which gives the packages according to the severity of the disease rather than the basic rates.
Exactly,
So that is
my point, because I know DRG, Dr. I think Swaminathan, somebody your group is doing that. So that's what my point is, that DRG system or RVRS, whatever is, if it is depending on the resources required to treat a patient, that if that is linked that way, then that would be more feasible.
I agree on that. And I think what you are saying, and everybody who was expert here also wanted to address that. And once you give 40% of population as the coverage, then there is to be rates which are slightly lesser than the rates which are available in the market. That you can understand. It's a collective bargaining thing, and if
Up to secondary level care, I mean, 4,800 rupees can be something to bring everybody.
see the rates are revised. I'm telling you again, the rates are revised, but the state is not having. Which state you are from?
I'm from Bihar right now.
So Bihar has not taken 2022. If it takes, then it will have new rates. But the Bihar government has to decide on that, because they also give 40% of the fund. So we give 60 and they give 40. So that makes the 100 rupee which you receive if you receive 100.
Yeah, but the base rate is still not something which can meet out the. I take this point of DRG. If DRG, maybe we have to wait until DRG.
Yeah, it's going to be complete. The pilot is going to complete soon. But still, whatever the issues are, definitely you need to write to the state government, because if even the rates are there, the state is the person who has to decide, because there are funds which are available and it is to be given to a particular amount of people. So the pie is small and the pie is there. You can't spend more than the pie, because the pie is a what we say is an exact amount. So you can't.
No, the saying is no. The other side is always green.
I understand.
I have from both the sides. I understand what you are saying.
Continue.
Yeah.
Sure.
Thank you.
Thank you, Dr. Santosh.
Thank
And,
you.
yeah, Dr. Tanvi Verma. Dr. Tanvi Verma, raise her hand. And one more hand is raised, is showing as Deputy Medical Superintendent SDM. Unmute, you could unmute and ask the question.
Good afternoon, sir. This is Tanvi Verma from JNK. Sir, as Dr. Saab has said, we have to register our hospital under HPR ID, right? And we already have our HPR ID under our hospital has been
Hospital has,
empaneled.
hospital has to
Yes,
register the
and
HFR ID. HFR ID.
yes, sir. Yes, sir. Actually, facility registry. So, sir, we have already done it, but still, whenever we submit claim, it always shows ki, whether you have it or not, and then we submit on yes, and then we
This
further
is this
proceed
is
with the
this is
process.
this is the thing which I have done recently, because we want everybody to register their and we got 1,000 hospital register within 3 days. Earlier, when
Yes.
this thing was not there, the PMJ hospital was not registering, because we are going to stop the payments to all the hospitals which are not registered on from 31st most probably, and
Yes.
we wanted everybody to register and have to have that warning message every time they do. So we can't do it only for the people who are not registered. It's not possible in.
Exactly. And we
So
get confused
you have the
whether
option.
it has been
No,
done
no,
or not.
no, no. You have to write. There's an option. You're registered or not. When you're registered, it's
Yes.
fine. You can click on that and it goes off.
Yes, yes, sir. We click on yes and then submit the claim and then proceed with the claim
Yeah,
initiation.
but it will be there for some time, because once it is there, the people are. This is nudge theory. I don't know you have heard it or not. There's a book on the nudge theory. If you nudge
Yes.
somebody to do something, they do it immediately. If you don't,
Yeah.
if the nudge is not there, you don't. So, like children keep in their room, I have to study for 4 hours. So, the poster is a nudge.
Exactly, exactly. That's like a reminder,
So
matlab
this,
for
this
everybody.
yeah, that is a nudge thing which I learned through our British friends. So they have trained me in nudge from the nudge unit.
There's a
So,
Nobel Prize in economics for nudge theory, actually.
so
Exactly. But every time we do it now, so we get confused whether we have
no,
done
no,
it or
you
not.
are
Even I clicked on the link also.
you have done it once, so it definitely will be done already.
Okay, thank you so
A
much, sir.
thousand tested in 3 days, though you can understand you are
Okay,
tested for sure.
okay, okay. Thank you, sir.
The one who is labeled as Deputy Medical Superintendent SDM.
Yes, sir. Good afternoon. My name is Dr. Magdoom. I am Deputy Medical Superintendent of SDM Medical College, Dharwad, Karnataka.
Yeah.
Sir, we have been running Ayushman Bharat scheme through the Ayushman Bharat Arogya Karnataka, which is run through the special purpose vehicle by Government of Karnataka called Suvarna Arogya Suraksha Trust, that is SAST. Sir, we have been doing this almost since 4 years now. The major challenge which we are facing, sir, because I wanted to bring it to your notice since at the policy level, because the other operational issues we have been trying to get it addressed by the SAST, but then the policy level, what we are facing is, sir, first the implants in case of orthopedic surgeries or say neurosurgeries where the coils or some implants are used. There is a difference of cost, a lot of variation, where the titanium implants or such implants which are being preferred by the patients and by the orthopedic surgeons are quite expensive. But the package itself, the implant cost is almost equal to the package which has been set by the SAST. We have been trying to raise this issue. The problem is that they say that you go for the least expensive implant which is available.
Are
But
they available? Are you saying those least amounting or least cost implants are not passed by the committee of which passes those implants? Is it so?
Sir, I mean, the cost, we have the certain amount of implants which we have been approved through our clinical quality control team and the purchase committee.
I'm again asking, is it not part of the Indian government as an implant which is suitable for any patient?
It is, sir. It has been
So
approved.
the question is already answered by you. So I can have an
Sir,
Apple phone or a Samsung or a Nokia phone, but all the purpose, if it serves to call, then it is fine. The basic purpose, it should not harm the patient. If you're saying it harms the patient, then please write it down about the name of
okay.
the implant and the implant which harms the patient. If your committee writes it down, then it can be assessed by the state government and it can be challenged again by the quality committee team, which is they definitely will be the experts from the field. And do you know that there's a committee which is there for orthopedic implants? There's a committee which I have recently made too for
Yes,
orthopedic. There are eight
yes.
people, the senior most people from AIMS, Nagpur, and AIMS Delhi, Safdarjung, Chandigarh PGI. So these people pass it. So you can't challenge that thing actually, because the people who are the orthopedic surgeon of the highest level have are the committee members. And if yes, again, if you find that thing, then something which has passed is not up to the mark, please raise it in black and white to the state government. And the Karnataka state government is very, very positive. They have recently started. I have done a recent scheme with them. The state government is also going to become cashless. That I have just done recently, and you must be treating those also. So,
Yes, sir.
the rates are being fixed as per the pie. That's what I'm saying. A quality thing. Again, I'm saying the quality should not be compromised. If you feel it is, please write to us that this is a low quality thing, and but don't say that Samsung will not do and Apple will do. That is not right. But if it is not even talking to the patient, the person, the phone is not talking, and this just like a dead thing, then you should definitely write to us. But don't say that a hospital committee has not finalized it. There can be so many reasons for not finalizing it. So you have to see if the implant which is that cost is available, is it good quality or not? And if the quality is bad, then definitely it needs to be addressed for sure.
Sure. Thank you so much. And the other question which I have is, some of the patients get admitted for a particular kind of surgery or something like that, and they have some associated comorbidities. Now, there is a provision set by the SAS that we can raise some enhancement related to it, or we can raise an additional package. But the problem which we face regularly is when we are managing these comorbidities, it has always been conveyed that it is a part of the complication of the surgery, or during the surgery it is a part of the. So how are we to manage these kind of comorbidities associated during the time of surgery when we have already got an approved package for?
So that's what we needed to address, and we got that point. I think I just made that point clear earlier that we are going to do the DRG thing, and that's why the DRG thing came into place, and we had consultation with several countries which are already implementing it, and we are running a pilot project, because definitely the simple gallbladder and a gallbladder with the diabetes and hypertension will be having different kind of expenditure. So we are onto it, but a child cannot grow on the first day and have beard on the first day. So definitely, like you have raised the query, people have raised the query, and we have understood the system, and we are going to evolve and definitely address the stakeholders' problems, and definitely will be solving this issue. But ये नहीं अगर complication है उसका किसी भी चीज का, जिसे हम मानते हैं 30 दिन के अंदर 30 days, it is the time, anything related to it is treated as a complication. And we call the patients also on second day, and earlier we were calling on 15th day, but I have changed it to 30 days. Now the patient gets a call on second day as well as 30 days to see that the hospital has given the medicines or not, post PTCA or any surgery, and on the 30th day, are they fine or not? So the state is looking into it, and then they try to reach out the patient also, and the comorbidities definitely has to be a part of it at present, because there is no DRG at present, but it will be soon, hopefully. Any other question, dear?
Yeah. So, Dr. Rajesh wanted to say anything? Dr. Rajesh Bhalla?
Yeah, Dr. Bhalla came live
Yeah.
again.
Yeah, you are still muted at the moment. You have to unmute. Yeah, now you are unmuted.
Can you hear me? Because my
Yes, of course.
screen is frozen.
Yeah,
I've been
I
trying
know.
to get it going, but I think somehow it's
That's
You're
all.
audible, sir. You're audible. Please tell us. Go forward.
No, all well, wonderful, nice conversation and nice discussion and good inputs. And I think we should continue on with the same thing. I have nothing more to add. I think Dr. Pankaj has already elaborated a lot, and Rajiv, you moderated it beautifully.
Thank you so much. Dr. Hemchandra has joined. Dr. Hemchandra would like to say anything. Dr. Hemchandra is the Vice Chancellor of Hemati Nandan Bahuguna University in Uttarakhand.
Thank you, Dr. Jain. Thank you very much. Sorry, I could not join earlier, so I was busy. So from my side, there is no comment as of now, basically. So I hope it was a very good program organized by the AHA, and I'm very glad that Dr. Pankaj Arora is with us now today. So thank you, welcome, Dr. Arora. Thank you very much for your brilliant presence with the AHA, and I hope in future you will continue your support to us. Thank you very much. Thank you.
I am from Uttarakhand too. Actually, I am born and brought up there.
Oh, that's fine.
I have visited a lot of hospitals in Uttarakhand as such, and during my visit in Ayushman Bharat. And I know the CEO very closely. Mr. Chauhan is there as a Uttarakhand CEO at present. He's looking after it. and Dr. Kotia is looking after the scheme beautifully. And Uttarakhand was the best state. Recently, some slight payment problems were there because of some IT issues, but now they are again going to be on track. So I think Uttarakhand is one of the best states to implement the Ayushman Bharat. It has been the forerunner and trying to include everybody, and went to USC as the first state, followed by J&K. So you have every patient which is there as a beneficiary of the scheme kind of thing.
Yes, very frequently we have the meeting under the supervision of Honorable Minister for the Medical and Health and Medical Education. We review the situation within the state of the Uttarakhand in regards to the PM-JAY. And I think the Himalayan Institute Jolly Grant is the best in the country, which runs the Ayushman Bharat and the PM-GSY program. So that is the basically proud for us. We are executing this particular program and getting benefited for all the state population basically.
Yeah, the HIMS was 20 kilometers from my place, my house. So
oh, that's good. That's good.
Yeah.
Nice. In fact, it is very fortunate for me that I could just open this.
So we'll definitely connect. Rajiv sir is my mentor from very beginning, so I cannot say no to him anytime, sir.
No, that's fine.
And he has been guiding me regularly in my life, so for sure, sir, definitely.
Thank you very much for your presence. Thank you very much, sir.
Dr. Tasneem Madani would like to ask any question. Dr. Tasneem.
Tasneem, and I'm from Psychiatric Diseases Hospital, Srinagar. I'm working as Assistant Nodal Officer, AB Sehat there. I have two issues which we have not been able to resolve till now. One is that in our hospital, we get psychiatric patients as well as substance abuse patients who are admitted with comorbidity or without comorbidity. The ones who are admitted with psychiatric comorbidity, they get enrolled in the AB Sehat scheme. But we have a big chunk which is only substance abuse, and they are admitted for rehabilitation. They are not covered in the scheme as yet. One issue is that.
Just to complete that before you ask another question, the alcohol abuse thing has been slightly included now. One of the packages has the alcohol abuse thing, but the other substance abuse has not been a part of it. Yes, please, you can continue.
Yes, sir. Okay, sir. Thank you. The second issue is that most of the patients who are admitted in our hospital, they are admitted in the chronic wards. Those patients are sometimes without attendance. Sometimes they are brought from places not known. Sometimes they are of unknown address. So they do not have any Aadhaar cards. They do not have any identification with them. So that huge chunk of patients, we are not able to enroll in the AB Sehat scheme. So there is no way how we can include them, and they miss out on the benefits. So I would like to know how to proceed.
I'll just brief you on that. Actually, our scheme, what I have implemented is that there should be no treatment if you don't have Aadhaar. That is a primary thing with us. And now we have taken off any kind of OTP also, which should be used for the treatment. It can only be by authentication by way of iris or fingerprint. Otherwise, the newest technology which we have introduced is the face authorization, which was used earlier in several other countries for airports, and now it has been used with us it matches 65% of you, and then it clarifies that it's you, and it does it in 10 seconds rather than 2 to 3 minutes, which is taken by the other parts. So now coming to the question that the Aadhaar jiska nahi hai, what to do about it? So those people, the state government has to take the note of it, and that the NHA cannot have a policy on that because it's something which is a state subject, and if they think that a package should be there or a policy should be there for those people who don't have Aadhaar, they have to make it. But we can't allow any treatment under Ayushman Bharat PM-JAY for any patient who doesn't have Aadhaar.
Thank you so much, sir. Thank you.
And Dr. Varsha Vadokar would like to ask. Dr. Varsha. Dr. Varsha, you have to unmute and then ask the question. I believe she's finding it difficult to unmute. So I would now request, yes, you unmuted. Yes, go ahead, Dr. Varsha. No, she's not able to. So since there are no further questions, no hands raised, I would again ask our President, Dr. Yashpal Sharma, to make some comments before we uh, close today's webinar.
Thank you, Dr. Pankaj. In fact, it has been a wonderful presentation, and Dr. Rajiv, you coordinated it very well. Congratulations to you also. And I was really happy that there was so much of interaction, and especially from J&K people. A lot of people got connected also, and they asked questions also. And then we can only say is that Ayushman Bharat Jan Arogya Yojana implementation has been a game changer in healthcare sector. Especially its implementation has helped poor people a lot. And in our state, we are lucky to have it for all by the name of Sehat. And especially, I must admit that, the private sector is coming up very well with the implementation of the Ayushman Bharat. In our state, the private sector has not grown too fast. But I'm sure that with this implementation of the scheme, many new hospitals are coming up in J&K, and they will be helping us because at present the entire load is on the government sector. Similarly, is the position in the entire country, and this scheme is wonderful and is being implemented. It's growing, every year it is growing, it is improving, and I'm sure that with it in the coming year, it will help the patients a lot. Thank you very much once again, Dr. Pankaj. I'm very grateful to you. Thank you, Dr. Rajiv, for getting him here with us. All the best to you, Dr. Pankaj.
It's a pleasure, sir, always, please.
So, in the end, I would say we have enlarged our knowledge as well as ensured that people in not only in the hospital sector, people not only in the government sector, people not only in the private sector, ultimately the common man, the citizen of the country, which will be taking the benefit of the hospital services through PM-JAY, through a unique collaboration between Government of India and the state governments. And I would, in the end, would like to inform the viewers, people who may have missed some part of it, that this recording would be available on the AHA India YouTube channel for you to watch a recap and also enlarge the discussion through the social media or YouTube channel. You could comment and you could interact there as well following the closure of today's session. So I would again like to thank Dr. Pankaj. You've taken your time from your busy schedule today to enlighten us, the galaxy of hospital administrators that were present. And it was refreshing to find a good number from Jammu Kashmir attending and interacting and raising their queries during the session. Thank you so much.
Thank you, sir.
Thank you, Paul.
Thank you, sir. And at last, I'll just nudge you to register yourself to the hospital facility registry as well as the hospital personal registry. All the nurses, all the doctors should register there and definitely get the incentive through it. It is available.